can see them, Emma.
Oh, okay, cool. So I'm Emma Park. I'm a GP at Healy Green, and I'm the clinical lead for cases, primary care, sexual health, and gynecology. Um, so if you've got any questions, it was brought to my attention that when we talk about cases, we tend to focus on GPs rather than nurses, even though there's absolutely no reason why nurses can't refer through cases. Um, I hopefully am going to show you a video um, that was set up which explains the overall idea. Ah, Katie, yes, I wasn't convinced I was sharing my slides, so let me just check. Okay. Oh, brilliant. Excellent. Here we go. Is that better? Um, Katie, can you see them now? Yes. Okay, so I'm going to hopefully show you a video which was explains the whole concept behind cases, and hopefully better than me. It's about 2 minutes, and let's hope the tech works. Okay, so that was just a brief introduction. I apologise for the people who couldn't hear the sound. I will send a copy of the link um, so that you can watch it later. So the main idea behind cases is that it's a clinical assessment, support and education service. And I like to think of it as a referral optimization program. So the idea is that we try to get the patient the right care in the right place. I was saying to some colleagues earlier in the practice, I don't know about you, but I just find that healthcare is far too complex these days. There are too many things to remember, too many referral forms to remember. It's just impossible to know where to send patients. And the idea is that if in cases you've got GPs with a special interest in different specialities, and they at least will know where to send your patient if you don't. Um, so how we work, let's explain. So referrals, except for urgent cases, because we don't do urgent things, are made by the patient's practice via the ERS to cases at PCS. Now I'm a little vague about this because usually it's the practice secretary who does it, but you can ask the practice secretary to search for cases and it is available on the ERS. GP with a special interest in a particular speciality area reviews the referral, and the outcomes are either the referral is forwarded to the hospital or advice is returned to the referrer or the GP to consider managing the patient. And this process should take no more than 3 days. And in fact, we process the vast majority, over 90% of our referrals within 2 days. If the referral goes to the hospital, then the hospital directly contact the patient about their appointments. And the specialities we cover are cardiology, dermatology, ENT, haematology, general surgery, gynae, gastro, neurology, urology, and respiratory. And that includes colposcopy referrals for gynae. So again, if there's someone and you're not quite sure, you can pass it through to cases. We can have a look. We can say whether it meets the criteria that Rachel was talking about, or we can give you suggestions for things to do in general practice. Um, these are the outcomes that we code. So sometimes we write back because we haven't got enough information to process the referral. This is particularly key in things like dermatology, where the dermatologists need to know what's been tried, and particularly for acne, because there's specific criteria about how long they have to have been on treatment for. Again, in my own case, so you probably use loads of gynae examples because that's the one that I do. But if you've got someone who is convinced or concerned that they might have premenstrual dysphoric disorder or PMS, gynae won't do anything until they've completed a 3-month patient diary of symptoms. So sometimes what I'll do is I'll write back and say you haven't included that in your referral. Sometimes what I'll do is I will refer the patient onwards because we know the gynae waiting list is absolutely horrendous. But I'll write back and say, could you get the patient to do a diary in the meantime? Because then that speeds everything up and streamlines the process, because that way the patient doesn't wait a year to be seen by gynae and get sent home until they can't come back and have any treatment for 3 months until they've filled in the symptom diary. But again, it's impossible for us all to retain that kind of level of information in every specialty. And so that's the beauty of cases. Sometimes it's incorrect speciality, so there are some things we can't refer through that get directed to us, but generally we'll be able to tell you which the right speciality is. So again, a gynae example is I get frequent referrals about assisted conception. Unfortunately, I can't pass stuff through to assisted conception. It all has to go through assisted conception at the GESET, but I'll generally explain that. Or we'll refer them through to gynae. So just for your own interest, in terms of what we send through, we send through the vast majority. So it's not that we're sat there batting every referral back. It's we send 85% through. And the most that we send back is with about 12% with guidance, and that's across all the specialities. They're all very similar. There are a couple of outliers in respiratory and a couple of outliers in that more stuff goes to dermatology, and that's just because, as I'm sure you can appreciate, it's difficult to assess a referral by letter. In terms of advice given, we give advice in quite a lot, and you can see that respiratory and I think that's urology give probably the most advice. We're quite good in gynae, but we do give helpful advice. One of the interesting things that I've noticed since we've had our new system is that often the peer reviewers get into a bit of a dialogue with the referrer. So the one that I recall seeing most recently was one from Marlene, who is one of the nurse practitioners over at Darnall. She had referred a patient in, and the case's peer reviewer gave some advice, and Marlene followed the advice. Unfortunately, it didn't work, so referred the patient back, and the peer reviewer passed it through. But at least then that way, hopefully by the time the patient got to hospital, that means that the patient will have had everything, and so they'll be able to get straight to the point once they get to secondary care. Referral letters, this is just some brief advice. I feel like I'm teaching my granny to suck eggs. You probably know this already. Brief history and examination, past medical history, drug history. What really helps us is if you ask a clear question. So one of the common things that I have in gynae is that patients are being referred up with concerns around gynae symptoms, but also concerns around fertility. And the thing is that because of the way the system is set up, gynae will not start fertility treatments, but assisted conception can treat gynae symptoms. So it's always helpful to know what is the patient's main concern. Is the patient's main concern their PCOS symptoms? Because in that case, yeah, they need to go to gynae. But if their main concern is actually getting pregnant, then they need to go to assisted conception first off. And this is particularly key in gynae because, as you probably are all aware, most of the treatment for gynecological stuff stops you getting pregnant. So that's why it's really helpful. And let us know what's already been tried. Again, I said that's helpful with acne referrals and hematology referrals. We don't always have ICE access, so it's helpful if you mention anything relevant results. In terms of useful resources, we've got a web page which I get the peer reviewers to put up useful things. The press portal actually has heaps of really useful pathways, quite a lot of which the peer reviewers have developed. And the intranet, the CCG has got a medicines and prescribing page, which again has loads of referrals. Unfortunately, and this is beyond my control, it's not terribly user friendly. So it is a case of like hunting around and seeing. But often, again, if you write a question to the case's peer reviewers, they will write back with web addresses in their response. In terms of future developments, I'm in the process of trying to get the peer reviewers to record podcasts on various topics. I'm hoping to launch that in January. And also in January, we've got a PLI. I haven't entirely decided which specialities are going to present, but you're all very welcome to attend. And all the teaching will be based on referrals. And that's everything I've got to say, unless anybody has got any questions. And I will try and figure out how to stop sharing.